Welcome to The Doctor's Daughter. I'm Kim Lynch, a doctor's daughter turned public health researcher and healthcare entrepreneur, helping clinicians get paid fairly and patients get better care.
And I'm Dr. Dan Roach, a physician informaticist, a father of twin daughters, and a healthcare technologist on a mission to make healthcare work better.
Where we're demystifying healthcare, one bite-sized story at a time.
At one of our OBGYN offices that we provide telepsychiatry services at, a young woman married to a Marine who was deployed came in to see one of our providers, and during that meeting revealed to our provider that she had written a suicide note and was planning to harm herself and her two children. And luckily, by that intervention, that our team here was able to help that young lady to get her the resources that she needed to not only help her, but also helped her family as well. Her husband did get deployed to move to a different military base, no longer in our community. But the last we heard that she was doing much better and her family was much better. That is probably the most impactful story that I've had in my 20-some year career in healthcare.
That knocks me out, how powerful that one intervention was for that mom, for those kids, for that family.
And kind of the neat thing about that story is telepsychiatry was not the initial ask for this program. It was actually for OBGYN for MFM specialists. And the OBGYN practice needed help on how to set up telehealth. And we said, hey, we can help you and also bring her on telepsych. So many stars lined up for this situation to help this lady and her family. I don't know what would have happened, but we all could take a guess. It wouldn't have been an outcome that most likely would have been positive as it was.
And in 2025, that kind of access, that care, that life-saving care is at risk. This is our topic today on The Doctor's Daughter. I am Kim Lynch, a doctor's daughter turned public health researcher and healthcare entrepreneur, helping clinicians get paid fairly and patients get better care.
And I'm Dr. Dan Roach, physician informaticist, a father of twin daughters, and a healthcare technologist on a mission to make healthcare work better.
Ryan Baker. I am the administrator of the North Carolina statewide telepsychiatry program based in North Carolina, and I'm based at East Carolina University in Greenville, North Carolina. Now, I'll say Greenville, North Carolina again, not to be confused with Greenville, South Carolina. We're located 1.5 hours east of Raleigh, between Raleigh and the Outer Banks.
I'm Lloyd Sirmons. I'm the executive director for the Southeastern Telehealth Resource Center, one of 14 federally funded telehealth resource centers around the country. We provide technical assistance, education, outreach around telehealth and telemedicine. I cover the southeastern portion of the states, more specifically Alabama, Florida, Georgia, South Carolina, Puerto Rico, and the U.S. Virgin Islands. That's my territory. I do wear a couple of hats. I mean, along with the resource center work I do, I'm also the executive director for the Georgia Rural Health Association. So there's a lot of crossover with the work that I do from a telehealth standpoint, the work that we do from a rural health standpoint, because a lot of that, it's a focus on a lot on rural health. And so that's what I get to do day in and day out.
Well, Ryan, Lloyd, thank you so much for being with us today. And we love to start off our episodes with a win of the week. So for listeners, you may have already guessed our topic today is telehealth in 2025. And before we get into that, though, I'd love Lloyd, Ryan, Dan, I'll kick off and share a win of the week. For me, around here in Maryland this week, the win has been to get outside for more regular walks because it's finally sunny here. And boy, howdy, have I needed it in this last week of February. So my win of the week has been getting outside for more regular walks.
Yeah, I will, my win of the week, I'm actually going to go back to last week. We had snow and ice here in eastern North Carolina, which working in telehealth, you can work from home. So my whole family was home, and I believe that's the first time in a long time where we sat at home for 3 days straight, all together with no agenda, nothing to do, and it was just nice to do that. Now, we were ready to go back to work and go back to school. But it was just cool to not forced not to go anywhere and forced to spend quality time with each other.
Love that. Talk about turning lemons into lemonade. Well done.
For sure. My win of the week. Yesterday I celebrated another birthday. So anytime you get to celebrate another birthday, kind of when you get here, it's definitely a win, right? And
Yes.
So I did get to share. One of my presents was the new Galaxy Bud 3, the Pros, and so I'm super excited. I've already got them charged up. We're ready to roll. Not an Apple guy, so I know all of you are probably Apple folks. I'm not. It's in my world, it's still PC.
Yeah.
Mhm.
And Android, so that's the platform I run on. So
Love it. That is
Awesome.
a great win of the week. And congratulations. I am also a big believer that getting older is a privilege, and heck yes, that's a win. Well done.
Mhm.
Absolutely.
and I
Yep.
tell you too, so I work for an organization, a small not-for-profit organization, mind you, but they give birthdays off. So when your birthday rolls around, you
nice.
get to take the day off, chill. So yesterday was a very relaxing day, no grants to, work on or anything like that. And so, yeah, it was great.
Well, so my win of the week, I have been working on a query for 2.5 days, and it had me stuck. And I solved it about 2 hours ago. So I am
Yes.
celebrating right now. It feels really good.
You are
That
hanging
takes
out
me
with the
back to
right
my main,
nerds.
yeah, that takes me back to my mainframe programming days, Dan. That's where I started out. I
Mhm.
think I spent about 6 months in that world, and
Mm.
I remember running, writing code and then waiting for it to blow up, So I feel you, man. I know where you're coming
Yeah.
from.
Yes.
I got out of there as quick as I could.
I like to stay in it. It's fun.
Well, let's just dive right in on our topic for today because it's meaty and we've got a lot of ground we want to cover on telehealth here in 2025. Brian, thank you so much for sharing that patient story up at the top. And Lloyd, I want to pass the ball honestly right to you to talk about why this access matters so much.
Well, telehealth, when I started almost 15 years ago in this space, telehealth was, the mindset around telehealth and virtual care was that it was going to be, kind of that piece to be able to connect people in the rural parts, and so to specialty care and to providers. And so I think what we began to realize just as time went on was, access to care is not just a rural health issue, right? So we began to realize that people in Atlanta, people in Miami and people in these large cities, these large metropolitan areas, and even a lot of urban areas still face, access issues. There's just not enough mental health providers, and that studies show, we heard Ryan's, story a little bit earlier that there's just not going to be enough providers to be able to keep up with the amount of care that's going to be needed. And I think that this is where virtual care shines. But it's not, and not just mental health. I tell people, technology enabled care, virtual care, whatever you want to call it, telemedicine, and it's not going to be a fit for everything, but there's a lot of things you can do. And if it really comes down to someone who has no access and you're able to give them access through virtual care, that's a win for all. So
Absolutely.
I love hearing that. And I
Yes.
started out in rural health and in my technology work 20 years ago. And I loved the necessity that you're talking about, Lloyd, that drove pragmatic innovation. It meant that it had to work for access for exactly the use case you describe of, look, this person either is not going to get care or they are going to have some sort of telehealth or virtual access. Those are our options. Go ahead, Ryan, please.
Yeah, I echo everything Lloyd just said there. It's and this is going to sound very cliche, but where someone lives should not determine the health care they receive.
Amen.
And
Yeah.
just because someone lives in rural, name your state, doesn't mean they should receive the same quality access to the same quality health care that someone in the urban areas can receive.
Absolutely.
But so to Lloyd's point, there are people now our focus is mostly on rural and underserved areas, but Lloyd is correct. Even in urban areas, there's access issues. But just because your zip code and shouldn't determine what your health care that you receive is, and we all know right now that plays a big, not only your health care, your access to food, education, and other items as well. And we're in 2025. We should be using the technologies and the resources we have available to break down these barriers, in my opinion.
Absolutely. Yeah.
You're getting nothing but nodding heads here. And two of the use cases we've already talked about for parents, the ability to have telehealth access in any setting, rural or urban, as a parent with a sick kiddo, as a caregiver to someone when it's icy outside. I mean, we could come up with an endless list of those use cases. And I love what you said, Ryan. No, your zip code should not dictate the access to care you have, and yet it does. And you're exactly right that we should be using this innovation to correct for those imbalances.
Yeah, it's easy to say everything I just said there. It's not, well, how I want to put it, we're not reinventing the wheel, but it's a lot of hard work.
Yeah, it is.
Saying the words is easy, but doing the work is the hard part. And you've got to, it's a team effort. And that's this conversation, if anyone listening getting out of it, it takes everyone, but everyone's got to be willing to do their part and to help out. You can't say, I'll let someone else do this or one who's going to do that. It takes us all doing, not rocket science, but doing a little work.
That makes all the sense in the world. And to that point, that it's not as easy as it sounds, let's talk about the current landscape and what's changing before we get into what people can do to take action next. And Ryan, by all means, take that, or Lloyd, you actually did a beautiful job of summarizing the legislative landscape with telehealth, and it really is in flux right now.
Lloyd, you go ahead, and then I can you get a better global perspective if you want.
Yeah, that's fine. I think one of the issues around virtual care that we've just seen is that telehealth and telemedicine's governed at the state level, right? So outside of Medicare, of course, you have Medicare, you have CMS, and that's what we are hearing so much about right now, in all the conversations. But outside of Medicare and CMS, telemedicine's governed at the state level. So what that means is each individual state is responsible for establishing their own policy, their own rules and regulations around the delivery of care using the technological means, virtual care. Reimbursement tends to come out of that as well. So in a state like Georgia, we have full parity legislation. So we have policy in the state that mandates payers to pay for telemedicine services at the same rate. So that's what we consider to be full parity. Then if you're, so where you're at, it matters when you're talking about telemedicine, because being governed at the state level, as you can imagine, there's, every state, no states get together and go, hey, let's create a telehealth policy together and we'll make it easy for everybody. Everybody does the total opposite. Just in my region alone, every state here does things differently. So the landscape in that telehealth, in that state is going to look a little bit differently. Medicare, though, if you're providing services to Medicare patients, then, you're going to have to go by Medicare policy. And Medicare policy right now is what we're hearing so much about. It's being one of the hurdles it's that telemedicine's governed at the state level. I guess it has its pros and cons, but there's some barriers there, I think, that we still face from a policy standpoint, because then you dive into licensure. Licensure becomes a little bit of a headache if you're providing services outside of the state. Credentialing, all these are things that we tend to, we run into on a daily basis. We're trying to help people navigate those waters as a telehealth resource center.
But let me ask you about the state policy. Are there any efforts to share best practices or states that have kind of done a good job with it, helping other states, whether it's at conferences or some organization trying to pull this together?
Yeah, so I've done some work with folks, and they'll call me up and they'll say, hey, what does policies look like other places? So I share those policies out. I think the biggest thing right now is the creation of the compacts. So a few years ago, there was an attempt to get reciprocity for physicians, much like what the VA has. I don't know, Dan, if you remember that move, but it wasn't met with fanfare, from licensing boards at the state level. And so there was really no movement. So what came out of that, though, were the compacts. And so I think the last I checked, maybe there were 13 compacts. So when I'm talking about that, I'm talking about like the nurse licensure compact. You have SIPAC, you have the medical licensure compact. What these compacts do is they say, hey, if you're a member state of the compact, you're licensed in that member state. It doesn't grant you reciprocity, but you do have the ability, maybe a shortened process to gain license. And so we're seeing more and more compacts to try to relieve some of the burden Because what virtual care does, right, is it tears down those geographical barriers and it allows providers to practice and provide services across state, no matter where they're located. So, licensure was a huge issue during COVID. So what we saw was states kind of letting their guard down, removing those burdens. But then once the public health emergency in the states went away, so did those relaxed measures. And so it's still something we're looking at. But the compacts are making a difference, but it's just a matter of the states jumping on board and getting in on the compacts. And so that's important.
Just to add on what Lloyd, great all points there. One of the things I'd like to bring up, and I'd be interested in Lloyd's thoughts on this, is on funding. When we see grants or external or even private funding from foundations, one of the things that I've tried to get out there is try not to be as narrow. I've seen too many of these grant opportunities as being too narrow. A lot of them focusing on bandwidth and just technology. And when I started in this role, and Lloyd knows this very well, I'm sure, 13 years ago, a system to set up telehealth and would cost $20,000. I mean, it was we called it Big Bertha. It was like a big cart on wheel, and you push it around. All you need is a computer and a Logitech camera for telepsychiatry. Obviously, if you're doing other specialty, that cost Moore's Law it's brought down. But I've seen a lot of the funding still being specifically mentioning those types of things. Whereas my biggest expense, and most of the people I talk to, the biggest expense has been the human capital cost. As we were talking about, earlier, there's not enough providers. Well, guess what? It's a supply and demand, and the prices for these providers has gone up, and the funding has not gone with that. So that's one of the big things that I've shouted from the mountaintop is we understand that you want to put parameters in grants and funding, but just not be as restrictive, or get the stakeholders at the table that are doing the telehealth, get the Lloyds of the world and others at the table to tell you what the needs are and what is seeing there. There's several grants that have come across my table and my desk was like, why don't you apply for it? I was like, I don't need $750,000 worth of technology. I need money to pay my providers in human capital.
Yeah, no, I think you're right. I think that, you see a lot of funding, which here again, broadband was a huge issue.
Yes.
So, it's sad, it's sad, but the United States lags behind. I think we were, last I checked, like 18 or something like that when it comes to broadband, which is crazy to me to think that the United States of America, we are who we are, and in 2025, we're not up at the top when it comes to broadband, but that's a whole nother conversation as well. But yeah, I agree 100%. I think that when you look at a lot of funding streams, you don't get a lot of funding out there to allow you to pay providers and things like that. A lot of times you get funding around equipment and purchase of equipment. Technology changes. We all know technology changes daily, and it's a very rapidly changing market. And the problem with healthcare and the delivery of healthcare is the majority of your changes in healthcare come through policy, and policy changes very slowly. So we have this conundrum where you've got technology moving at the speed of sound, and now it's inserting itself into healthcare in a lot of, really great ways. But then policy to allow the reimbursement and funding for certain things, like that, it's lagging behind. And so it's just...
And that technology is obsolete by the time they catch up with it.
Yeah, 100%.
Yep.
Absolutely. And so, I think that it's going to really take the hard conversations. And right now, this landscape, of course, is very shaky. And there's a lot of question marks. There's a lot of unknowns. The one thing that's not going to change is, we still have to deliver healthcare. People still need access to care. So
I love that point. And Lloyd, I would love for you to do another beat on Medicare. Since you teased it a couple of minutes ago, Medicare does, even though, exactly as you said, the states control telehealth policy as Medicare goes, so do so many commercial plans and such. So if you would touch on the Medicare changes a bit, and I love this point of the technology, exceeding the pace of policy change. And this is a perfect example.
Yeah, so we'll get together after March 31st. We can talk about Medicare because we'll have a little bit better picture, right, of what Medicare is going to look like. Because right now there's just a lot of questions. So, we were looking at a 2-year extension to a lot of the waivers, what we call, the COVID waivers, the PHE waivers out of Medicare, some of the things like the home being an eligible originating site, right? I mean, that's always been one of the big changes that people were pushing to have made from a Medicare reimbursement standpoint. But here again, it went back to policy, right? So you couldn't get the change made because it was a policy change. And so that was one of the things. And so that's what we're watching now. So we really felt like we would get a 2-year extension. It was a bipartisan piece of legislation. So everybody was, pretty confident that the piece of legislation would move through. I mean, I think the issue was it got lumped into the CR at the end of the year. And so we all know what happened to that. We got a 3-month extension, which means Medicare flexibilities got a 3-month extension. So whereas the CR will end March 14th, the flexibilities that were a part of that got lumped into the CR, and that's continuing resolution. So I don't want to just assume everybody knows that. So that's what kept the government funded moving forward. So because that got lumped in there, so now we're looking at March 31st for the COVID waivers. The idea, I think the feeling is that there's still going to be the flexibilities are going to get the extension because at the end of the day, I mean, it is still a bipartisan piece of legislation. There's a lot of support around the legislation. And I think people in general realize that telemedicine is going to still be the way that a lot of people receive care. And there's a lot of people receiving care right now that if they were to remove some of those waivers, it wouldn't be good. The problem, and I had this conversation with someone here just a few months back at our Rural Health Association conference, and my question's always been, well, why aren't they making these things permanent? And what Medicare or what CMS says is that it would just cost too much money to make all of these flexibilities permanent. Now, that's way above my pay grade. Like, I mean, I can't provide further answers into that, further insight into that. That's just what comes out is that's why we're continuing to see extensions. Some things made permanent, like some things around mental health, stuff like that. But that's why we're continuing to see these extensions. So long story short, we're waiting and we're watching for March the 31st. I think that over the next, couple of weeks, there's going to be more conversations that's going to be had. There's going to be more information that's going to come out. That I think will clarify a lot of things for us. But yeah, 100%, be more than happy to get on, after March 31st and let's talk Medicare. That'd be great.
I know that every doctor I talk to has this question right now. If they are doing any telehealth services, trying to understand their state of play today, their state of play in March, right? They understand through March 31st, pretty much all systems stay the same. But what does it look like after April 1? I'm so curious to definitely have you back then and talk about how things have evolved. I love how you are tying, though, the broader policy discussion always to the individuals who will lose access if they don't have this kind of support. And that to me is the why behind all of this, right? Like we've seen since COVID, tremendous innovation and tremendous care delivered remotely in ways that I think 10 years ago we couldn't have even imagined. Okay. It's really great to hear. Oh, please go ahead. I was going to say it's so great to hear that the mental health, for example, is sort of like staying in place. That makes me feel really good.
Well, and one thing, Kim, whether you run a business or you work for a practice or anywhere, if you have uncertainty, you're not going to invest. And that's what's interesting when I hear CMS and others say it's costing us too much money. My argument is you can't afford not to do it. Just look at what the innovation has happened since COVID, and it hasn't been the full thrust of funding from wherever because you don't know what the certainty is. Well, just like Lloyd said, it's 3 months. You can't plan, like Lloyd can't plan, I can't plan, we can't plan. We can't plan for after March, let alone for our next 5 years. We need some certainty, and we need to get some certainty so there can be more investments made in this, which will speed up the technology and will speed up the access of care. And like Lloyd said about CMS, what frustrates me is if they can't measure it, like see where the dollars are. It's hard to measure someone that doesn't go to the ED. You can't see that. We've got to get over this mentality. And I'm speaking as a private citizen here, not as a university. We've got to get over that and see that there is, just because you can't see the dollars, not only on a bottom line somewhere, there is savings by keeping someone from going to the hospital, or we've got to realize that. And that's what we've seen in North Carolina with our while we were developed, was to help with ED people in the ED in mental health crisis, and we've been able to measure $61 million in unnecessary hospitalizations in 10 years. But you show that to folks, the legislators are like, well, where's that money at? Well, that's money you didn't have to spend.
Well, it's not in your pocket, right? I mean,
that is what they want. We're showing you where that money is. Well, I can't show you where that money is because you never had to spend it because we saved it.
That point.
Voice about that one, Kim.
No, it's a good one, Ryan, and I love that because it's like a balloon where you squeeze part of it and it gets bigger on another side. What you're saying is we relieved the pressure over here, and so you didn't see the balloon squeeze out.
Correct.
You didn't see. That's a much more complicated story to tell. And I am with you that we need to move past it because it's holding it back.
And Kim, how do you measure that mother that didn't harm herself and those 2 children?
Nope. That's
for the dollar amount on that.
Nope.
And how many other times? That's just the one example. I'm sure there's been many, many, many more examples like that just with my team here and with Lloyd's folks he's worked with that you never hear about. Have we helped some kid that was thinking about? You can't measure that.
That is the perfect pivot point to how to take action, because that's why we're here. That's why this matters so much, because telehealth saves lives. It reduces suffering. It matters. So for our final segment, Dan and I really wanted to pivot to what can folks do? What can providers do to take action? What could patients do to take action? If I'm a mom listening to this saying, heck yes, I want telehealth services for me and my family if we have a need in the middle of the night, or for my, aunt that I care for who doesn't have great mobility when she needs help, where would you start, Ryan, to that patient and to that doctor who wants to advocate for more either and through policy or their employer even?
It's all of the above. It's if I'm a patient or I'm a father, and I'm going to tell the doctor, everyone I come in contact with in my healthcare journey, I'm going to tell them how critical or how much I wish I could do this via telehealth. And I'm talking about from the secretary when you walk in your doctor, anyone that will listen to you, but then your policymakers.
Yes.
Not only federal, but your state, especially your state legislators. That is, and like Lloyd said, this is, with all that's going on in our country and the political divide, this is one topic where we can come together and should be able to have a win on any state, local, or national level. This should be
getting the snaps. Yes.
Yes. And the more you talk about it and bring it up, no, we're not all experts even though I work in the telehealth space, I'm not an expert on it. I'm learning. So don't feel like you can't bring it up. And if you're a physician,
that's a good point.
Advocate with your organizations you're a part, your hospital systems and others. Share your enthusiasm or your thoughts, or express how you want to learn more about it. So with the opportunities, there are a lot of things you could do out there, and there's a lot of flexibility, and you can get creative with telehealth and do a lot of that. But just the conversations like we're having here today are the conversations that need to be happening at the dinner table and in the doctors' lounges. Across America.
Love that.
Because it is the only way that I know of due to the lack of resources and human capital as far as providers. We have to embrace this, and we have to embrace telehealth to provide, again, going back to my earlier comment, someone in a rural area deserves the same kind of care that someone else gets, and this is a way they can get that care.
And in terms of state policy, going back to that, I mean, how slow it moves, what do you guys see, or what needs to be done to speed that up, or what could be done to speed that up?
Well, in North Carolina, I will say it took a crisis, a mental health crisis, that back we had mental health reform, and all of a sudden the hospitals started to have patients that were hospitalized or in facilities were showing up in emergency departments. And man, did that bring everyone together when the North Carolina, at the time it was called the Health Hospital Association, said, hey, we got to do something. And that brought everyone to the table. And out of this was born the North Carolina statewide telepsychiatry program. Unfortunately, it has to get to a crisis level usually to get that kind of response. But humans, we respond to incentives, and I think we're incentivized now. And like Lloyd's talking about what's coming up at the end of March, now is the time that, hey, we should be yelling from the mountaintops. And it's all everyone, even at state houses or legislators, there's a healthcare subcommittee or something there that telehealth is on their radar. And that's a quick Google search of your state legislature and health, and you Google telehealth. You can find there's someone, I'm betting you, in your state house or senate that's a champion of telehealth, that's looking to, and if you could get behind those folks and just send an email of support or make a phone call. I know that doesn't sound like a lot, but they get that momentum, and you get that momentum going. That's how you do it.
You're exactly right. And
Excellent
with those
point.
stories, like you gave at the top, Ryan, Lloyd, I want to tee you up to take the ball from here, though. Please tell us about the telehealth resource centers. You've mentioned them briefly, but I learned about them through you, and now it's become my go-to stop for any doctor who's asking, how do I figure out where I stand today and what's happening in my state going forward? Yeah. I bet as well, though, for that advocacy point that Ryan's making.
Yeah, so, being federally funded, of course, we can't advocate or lobby. Right. What we do is we educate, right? So I think that you have to look for those opportunities out of session to talk and to educate people, on telehealth and telemedicine. I feel like there's still a lot of education that needs to be done around telehealth and telemedicine. And, going back like what Ryan's saying, comments matter. Conversations matter. The DEA put out its proposed prescribing rules last year, something that had been waited on. And it came out and it got over 38,000 comments. And, when you comment on Medicare policy or DEA, when you comment, they have a comment period. Like right now, CMS, the DEA has a comment period on some policies that they have, things like that. So when those comment periods come out, it's important to make your comments, because what that did last year for the DEA, it caused them to back up. They paused. They gave another extension because they have to read through people don't realize this. They say, well, my comment don't matter. Well, it does, because they are mandated to read through every comment that is submitted. So they have to read through those. So with the DEA getting over 38,000 comments, man, they backed off. And now we're seeing a little more telehealth friendly policy, coming around. So yes, number one, it does matter. The telehealth resource centers, as I said, there's 14 of us around the country. There's 2 organizations that are national. The Center for Connected Health Policy, or CCHPCA, because they're based in California. They do a really great job of tracking telehealth policies, what's going on at the federal level. They do some at the state level as well. They have some legislative trackers to where you can go in and you can track policy. You can see if it's in the health subcommittee, or you can see if it died in committee, all these little things. So, but just a lot of great resources. The 12 regional telehealth resource centers, like myself, every state is covered by a telehealth resource center. You need to know who your telehealth resource center is. I can't stress that enough. If you're in the telehealth space, you need to be familiar with your telehealth resource center, because it's a great resource for you to go to if you have questions around reimbursement, if you have questions around policy, if you have questions around technology. Those are the type of things that we can help people kind of navigate those waters. One of the calls that I get still today, most of, is, hey, I want to get started with virtual care. And you're like, wow, where you been last few years? But we have a lot of resources. We work together. We're totally autonomous, individual telehealth resource centers, individually funded, but we do pool our resources together. We work together as a consortium. So if you were to go out to telehealthresourcecenter.org, you would find just a website that's just full of and rich with just resource after resource, translated resources, best practices. I mean, all kind of stuff. We have videos that you can share with patients, like what to expect from a telemedicine visit. I mean, there's just a lot of stuff. The great thing about the resources that we create, because we are federally funded, is those resources are free. No reason to create the wheel, right? Speaking at conferences, we do a lot of that. Exhibiting at conferences, we do a lot of that. So there's just a lot. There's great resources at your fingertips. The services that we provide are free. So yeah, I mean, get to know your telehealth resource center.
And as a telehealth provider group, I can tip my hat to what Lloyd's saying. There's no need to reinvent the wheel, because what Lloyd just described is there, and you can use those resources. You have used them often, many times, but you don't need to go out and reinvent the wheel on a lot of this stuff. And people like Lloyd's organization are there to help you, and will help you and respond very quickly.
That's right.
That's awesome. And one of my favorite things you said when we first met, Lloyd, that has stuck with me is the simple idea of, to the person who calls you up and says, hey, we're thinking about getting started here in 2025. Your recommendation, you told me then, was you start with one service and you just start and right. And that one service, getting a couple of wins under your belt, you end up with a story like what Ryan shared at the beginning. And all of a sudden, my experience has been, now others are excited and want to try this new thing that this thing that maybe sounded scary when you first brought it up. But when you start hearing how it's really helping people, real people, your neighbors, well, now there's a little bit more interest and curiosity.
That's right. Yeah.
I love it. Well, we are coming up on time here, and I want to give both of you a last word. And Dan, anything else you want to pitch in to this conversation? This has been amazing. And I think, the closing for us is where can folks put their finger on the scale for what they want to see happen with their care or with their virtual access options. So any other final comments? And for our listeners, we are putting together a resource guide to accompany this episode. So don't worry if you did not write down all of those things that Lloyd just said. We're going to have it all in an accompanying resource guide so that it's easy to go find your telehealth resource center.
I would say the biggest thing is to ask your provider if they offer telehealth. One of the things that I find for talking to others is they might have telehealth as an option, but they're not promoting it to their patient base. So as a consumer, obviously we're all consumers of healthcare, but ask your PCP or where your provider is if they have a telehealth. Give it a try and see if it works. The biggest thing that I hear from folks is, I didn't have to take off a half a day of work to go to my doctor's appointment. I was able to do that. I was able to go on my lunch break or take a break, go out in my car and connect with my provider and do that. The other story will go is the number of, especially low income folks that have jobs that are hourly jobs. I should say folks that have jobs and like a fast food restaurant where the mother can't afford to take time off to drive 2 hours to a doctor's appointment. Well, she's able to go out there in her car and have an appointment with a provider, and she didn't have to lose a day's wage and drive her car and spend $50 on gas back and forth because she was able to use telehealth. And that can be that's repeated thousands of times, but just think about it from that level too. She was able to not, because they don't have paid time off or any of that other kind of stuff. So ask your providers if they have telehealth, and if not, ask them if there's an option of them potentially joining. Advocate for yourself for telehealth.
I think right on top of that, ask your employer if you don't currently have access, because for every employer I have ever talked with about telehealth has done the calculus that you just described, Ryan, and said, oh my gosh, of course I want my employees to have access to that so that they show up to their jobs. But that aha moment is not in benefit plans.
Yeah, and they should. It would behoove a company, like if I had a manufacturer, to set up a room based off Lloyd's suggestions from his group on a telehealth room where someone could go and have all the appropriate equipment there. The ROI on that for a business would be tremendous, and your output of that's the time we have to have.
Every employer benefits team member who heard that just wrote themselves a note to go explore what telehealth could do for your productivity and lowering your healthcare costs.
I guarantee you, your ROI on that how many the folds would be, because it's not a high investment on telehealth equipment.
But it's a huge impact on humans and on cost. Lloyd, what's your final word on this topic here at the end of February 2025, knowing the state of play is in flux?
I think, telemedicine's not going away. I know there's a lot of questions around maybe the reimbursement and what that looks like, but we've always said, and I've said this for years, there's two types of people, right? There's those that are doing telemedicine. There's those that will be doing telemedicine. There's too much of an access issue, and the access is not going to be solved without the virtual care piece. And so I think that it's not going to go away. There may be some adjustments in the reimbursement process, but I foresee that to continue to push forward. We've come a long way from where we were back. I started, like I said, 14 and a half years ago. We've come a long way. I don't see us going back. I know there's a lot of people who talk about telemedicine's taken a step back. I mean, I think if you look at where we are now and you look at where we were pre-COVID, we've come a long way. And I know there's a lot going on. There's a lot of uncertainty and things like that, but I don't think that telemedicine is going to go away. I think it's going to continue to push forward. I think it'll continue to grow. And so, there's a lot of people, they're going to get this thing figured out. There's no doubt about it. And so, I think that when we start, and I share this with people, and I believe this strongly, and, Ryan touched on it a little bit. I think that the hybrid model is probably where you're going to see your most successful practices, your health systems. And I say that because there's still a population of people who maybe want the in-person, or maybe the care model, calls for the in-person and the touch, but you're always going to have those people like myself who want the virtual care option, right? So give me the virtual care option. If I have the option of going into the office or connecting with you virtually, I'm going to take that virtual option. So I think in order to meet the needs of the entire population, I think that hybrid model is going to be successful. I think there's some areas where, and especially if you dive into the weeds with mental health, it just makes sense. Virtual cares, it just makes a lot of sense, but I still think that when we start looking at where healthcare is going to be in 3 years and 5 years, more and more healthcare is moving. If you really look at it, more and more healthcare is moving to the home. So what is that going to say for our large health systems that have all these really, big buildings and things like that? So I think that the hybrid approach is going to be a successful approach, especially when you start talking about primary care and, those type of applications where that's going to be conducive. So, but I don't think telemedicine's going anywhere. I see us continuing to move forward, and I think we'll just continue to grow.
Yeah, just one more comment about what Lloyd said. I think the winners in healthcare long term are the folks that are going to figure out how to get as close to the patient's home to deliver care, to keep them out of the hospital, to improve the quality of life. And I agree 100% with what Lloyd said. There's no reason why you can't go to your primary care practice location and have a specialist beam in via telehealth to provide care, instead of you having to drive 2 hours, whatever. And by keeping that patient in their community and keeping them out of the ED, those will be the winners. Those will be the models that we will adopt across the United States as being successful healthcare models, however that shapes and looks. But it's going to take everyone involved in healthcare is going to have to row that same way, I think.
And there's a paradigm shift that's happening. I don't know if you guys have paid attention to it, but if you look at ownership of the health record, who owns the health record? And what we're starting to see now is people taking ownership of their health record, which is a shift in the way it typically and traditionally has been. So
absolutely.
Well, I think we just found another topic for us to pull on another time, is the future of the EHR and how patients are taking that into their own hands. Interesting. I'm not as familiar with that, but thank you both. I didn't expect to be quite so uplifted and hopeful at the end of this discussion, but I really am. This is so exciting to hear both of you talk about, yep, things are in flux. but you can't unring the bell. And this is what people want. It's what the population needs, and it's working, which is really a lovely thought to have.
Exactly.
Yeah, it is. Yeah. Thank you both so much.
Yes.
Enjoyed it.
So
Thank you very much.
Thank you. For those listening, please check out our resource guide, share your thoughts in the comments, and let us know what questions you have, as well as your story, what's worked for you. Because I couldn't have said it better than Ryan did at the top. This is what we're all about here at The Doctor's Daughter. Our kitchen table issues you would hear as the child of a physician here in 2025, and the things that you would want your children to know as they go out and seek care and try to make their own way in this world. Dan, any final thoughts or words?
No, just this was an incredible session. The knowledge between you guys is incredible, both shared experiences and unique perspectives. So thank you. Yeah, thank you so much. This was really, really wonderful.
Yeah.
Enjoyed it.
You guys are awesome.
Thanks for having us.
Yeah, always a
Thank
pleasure.
you so much.
Thanks.
Well, we will see you again on the next episode of The Doctor's Daughter. And again, Lloyd and Ryan, hopefully on yet another telehealth or other virtual care topic. Thanks so much.